Assalamualaikum warahmatullahi wabarakatuh. Dengar?
Salam.
Salam, dengar doktor.
Waalaikumsalam, dengar doktor.
Okey, terus start dengan Al-Fatihah. Okay, so frankly speaking, my internet is not brilliant because I'm at home at the moment. So it's okay. Present. I didn't get the chance to view your slides. So how many presentation tonight?
5 Doctor.
Hmm?
5.
5. You. It's a long day today. Tapi try lah. Okay, boleh start kot. Okay. Make it simple lah, as simple as possible. Okay, boleh start lah.
Okay, Assalamualaikum warahmatullahi wabarakatuh. I bid to doctor and also to all my colleagues. So today our group will be presenting about hematological diseases, and my name is Siti Sarah Surfina binti Muhammad Zaidan. Next. And today I will present about nutritional anemia. That means the child is having anemia due to nutritional deficiency. But before that, I will briefly explain what is the process of hemopoiesis. Basically, the process of hemopoiesis is to produce all of these specialized cells coming from the hemopoietic stem cell, from the pluripotent hemopoietic stem cell. And why it is called as pluripotent? Because basically, pluripotent means that immature cells are able to differentiate into, are able to produce into many more different kinds of cells, which are much more specialized. And the main site of hemopoiesis in fetal life is basically in the yolk sac, between 0 to 2 months old. And then and then it will proceed to liver and spleen for 2 to 7 months period of gestation, and then postnatally this process of hemopoiesis will occur in the bone marrow. However, if our body needs higher amount of a higher amount of red blood cell, white blood cell, and also platelet, liver and spleen might also be involved in the process of hemopoiesis. So basically, in fetal life, we have this embryonic hemoglobin, which comprises of these 3 hemoglobin, which are hemoglobin GAWA1, GAWA2, and also Portland, which are produced between 4 to 8 weeks period of gestation. However, in later period of life, still in the womb, this embryonic hemoglobin will then switch to fetal hemoglobin, which has a higher affinity for oxygen, which means that the oxygen dissociation curve will then shift to the left, which means that the fetal hemoglobin are able to receive and absorb this oxygen much more compared to the maternal hemoglobin. And at birth, this fetal hemoglobin, hemoglobin A, and hemoglobin A2 will then be gradually replaced by hemoglobin A and hemoglobin A2 in the first year of life. So basically, the store of iron, folic acid, and vitamin B12 in term and preterm babies, they are adequate at birth. However, for preterm babies, because they need a lot of iron, so basically this iron storage are much more depleted compared to the normal baby. So that's why the requirement of iron in preterm babies are much higher compared to the normal babies. Next. Okay, so what is anemia? Anemia is basically a reduction in the oxygen transporting capacity of blood, which usually stems from a reduction of the total circulating red cell mass to below normal amount. And that is according to Robin's pathology. However, in general, which is according to illustrated textbook of pediatrics, anemia is basically defined as hemoglobin level below the normal range. And these ranges, it can be classified according to age and also gender. So this one is according to WHO, whereby it is classified according to ages. And here we can see that at birth, basically babies, they have a higher amount of hemoglobin compared to older children because they need a lot of iron for growth. Next. Next. Okay, so anemia, it can be classified based on etiology as well as morphology. Morphology means the shape of the red blood cell itself, whereby it can be either normochromic normocytic, hypochromic microcytic, and also macrocytic type of anemia. Macrocytic means that the size of the red blood cell is big, whereas for hypochromic microcytic means that the size of the red blood cell is smaller compared to the normal red blood cell. And also it can be classified according to its etiology, which is blood loss, impaired in red blood cell production, which means that a low amount of red blood cell is being produced, and also increase in red blood cell destruction. Okay, next. Okay, so among the common causes of anemia in children, this one is based on etiology. Okay, the first one is impaired red cell production. It means that maybe it is due to low amount of nutrition that causes low amount of hemoglobin in the patient's body, or it is due to the failure of the bone marrow itself to produce red blood cells. So it can be either due to ineffective erythropoiesis, which is due to iron deficiency, folic acid, and vitamin B12 deficiency, or is due to bone marrow failure such as leukemia, parvovirus, B19 infection. And it can also be due to increased red cell destruction, which means that there is hemolysis going on in the body, either due to the membrane of the red blood cell disorder itself, such as hereditary spherocytosis or ovalocytosis, or red cell enzyme disorders such as C6PD deficiency, hemoglobinopathy such as thalassemia and sickle cell anemia, or due to immune reasons such as hemolytic disease of newborn and autoimmune hemolytic anemia. And it can also be due to blood loss. However, it is relatively uncommon in children, but it can occur. And among the causes are fetal-maternal bleeding, chronic gastrointestinal blood loss, and also inherited bleeding disorder. Next. Okay, so this is basically how we can approach patients that is having anemia. Okay, so when we see full blood count result and it is indicated that the hemoglobin level is low, so we can say that this patient is anemic. So and then next, the next parameter that we can see is the reticulocyte level, because we are thinking about the etiology, what causes anemia. So if we were thinking that it is due to ineffective erythropoiesis, that means that the bone marrow is still able to produce red blood cell, however insufficient amount. That means the bone marrow is still working. So that means by right, when there is low amount of hemoglobin, the bone marrow will try to compensate by increasing the amount of reticulocyte. So when the reticulocyte normal or high, so we will focus, the next parameter is by looking at the bilirubin. If there is hemolysis going on, then the bilirubin will be raised. So we'll be thinking about hemolytic anemia. Whereas if the bilirubin is normal, that means there is no process of hemolysis, then it can be due to ineffective erythropoiesis or blood loss. And if we see that the reticulocytes are low, means that the bone marrow are not able to compensate the reduction in hemoglobin level, then it means it is due to reduce in red cell production due to bone marrow failure, such as aplastic anemia. Next. Okay, so first, iron deficiency anemia. Next. Okay, so I will explain about iron metabolism. Basically, iron is being absorbed in the duodenum and also in the last part of the small intestine, which is at the ileum. So here, when we take iron, there are two forms of iron, which is heme iron and also non-heme iron. Heme iron can be obtained from animal base, such as chicken, where non-heme iron can be obtained from vegetable base. And these iron are readily absorbed through heme transporter into the cell, whereas for the non-heme iron, Fe3 plus ion will then be converted into Fe2 plus ion, and then it can be absorbed into the cell, where both of these, heme iron and also non-heme iron, will then be stored by the ferritin. And if our body needs them, this ferritin will then release the iron outside of the cell into the blood circulation, where it will be transferred by plasma transferring either to liver or to the erythroid marrow for the production of hemopoiesis, specifically red blood cells. Next. Okay, so how much iron do you need? Like what I have mentioned earlier, basically infants and babies, newborn babies, they need higher amount of iron compared to adults, compared to other older children, because they need them to increase the amount of blood volume in their body, as well as for to increase the amount of iron storage, as well as for their growth. Whereas for males aging 14 and above, they only need up to 8 to 11 milligram per day. Whereas for females, they will need higher amount of iron because they have every month menstrual cycle. And for pregnant females, they need much more iron compared to the others because for lactation. And like what I have mentioned earlier, preterm babies and also those who are having health conditions such as stomach and colon cancer, peptic ulcer. Basically, the iron storage inside the body are much more quickly depleted. So they need higher amount of iron compared to normal people. Next. Okay, so for the sources of iron for infants, the main one is the breast milk, where 50% of the iron is being absorbed into the body. Or they can also obtain from infant formula, whereby they have adequate iron, but lesser amount of iron is being absorbed. Or they can also have also the or they can also take this iron from the cow's milk, which has a higher iron content than the breast milk. However, only 10% of this iron is being absorbed into the body. Or they can also obtain by solids introduced at weaning, whereby we give these cereals that is being supplemented with iron. However, only 1% is being absorbed. And like what I've mentioned earlier, among the sources of iron, there are two sources, which are heme iron and also non-heme iron. Heme iron can be obtained from animal base such as chicken, and non-heme iron, it is obtained from vegetable base. And the non-heme iron is harder for the body to be absorbed. And so that means when the body are not able to absorb it readily, so lesser amount of iron will also be obtained. So how can we actually enhance the absorption of iron in the body is by taking vitamin C. And among the examples of foods that have high amount of vitamin C are like tomatoes, fruits, and bright vegetable. And if you want to enhance the absorption of vitamin C, basically we have to prevent ourselves from drinking tea or taking phytates, which are high fiber, because phytates basically they can impair the absorption of iron, whereas for tea it can inhibit the uptake of iron in our body. Next. Okay, so iron deficiency anemia, it occurs almost in all countries, whether it is developed or developing countries, but it is much higher in developing countries, and it accounts for about 25 to 50%. And iron deficiency anemia is higher in poorer socio-economic groups, and it is the commonest cause of anemia in childhood. Whereas for infant, why iron deficiency anemia occur is due to inadequate intake of iron itself. Next. So among the etiology for iron deficiency anemia, it can be further divided into 4 reasons, which are the first one. The first etiology is due to inadequate intake, which is the commonest cause in infant. Or the second one, increased demand, like what I've mentioned earlier. Premature babies, they need higher amount of iron compared to normal babies. And also for those who have rapid rate of growth, such as toddlers. And then it can also be due to impaired absorption. Either it can be due to malabsorption or due to hookworm infection, for example, Ascaris lumbricoides. Usually the main site of Ascaris, it is at the small intestine. And like what I've mentioned, iron is being absorbed at the small intestine. So when there is infestation over there, lesser amount of iron will then be absorbed. It can also be due to certain diseases such as celiac disease and Crohn's disease, whereby for Crohn's disease, there is inflammation at the small intestine going on. And for celiac disease, the villi, it is supposed to be straight, upright, elongated. But in celiac disease, the villi of the small intestine, basically it become flattened. That's why lesser amount of iron is being absorbed. And it can also be due to chronic blood loss, such as parasitic infection and also Meckel's diverticulum. Next. Okay, so among the clinical features, the patients can present to us with symptoms of pain, lethargic, anorexia. It can also be associated with minimal jaundice, reduced activity, and if the patient have blood loss, they can present to us with hematemesis or an hematochezia. And the signs that we can look for in the patients are basically the hypovolemic signs, whereby there is tachycardia, tachypnea, there is also pallor, collapsing pulse, bounding pulse. There are also murmur, and in patients that have severe iron deficiency anemia, they can manifest with koilonychia, angular stomatitis around the mouth, and also glossitis. And infants or children, they can also have signs of cardiac failure such as tachycardia, cardiomegaly, and also bivessel crepitation. Next. So these are among the anemic symptoms, what I've mentioned. There is headache, chest pain, cold hands due to hypovolemia. Next. So this is an example of koilonychia. Okay. Next. Glossitis and also angular stomatitis. Okay, next. Okay, so among the investigations that can be done is first we can do full count, and when we see the result, it will show that there is low amount of hemoglobin, indicating that the patient is anemic. And also when we look at the MCV and also MCH, it will also reveal low, which means that the patient is having hypochromic microcytic type of anemia. And when we do peripheral blood film, there is presence of microcytosis, which means that the red blood cell sizes is smaller compared to the normal red blood cell with central pallor. And also there are presence of target cells, and also anisopoikilocytosis means that there are various shapes and sizes of the red blood cell. So these are what I've mentioned earlier. Okay, next. Okay, and if we think that the patient is having parasitic infection, which is more common among orang asli patients, so we can do stool or cord blood because we want to look for ova and cyst. And we can also do iron study, which will reveal low ferritin, low serum iron, and high TIBC. Why low ferritin? Basically because low of iron, so that means the iron storage will also be low. So when there is low amount of iron storage, low amount of iron can also be absorbed. And also when all the readily available ferritin has been bind with the iron, so there is high saturation of total iron binding capacity. And we can also do bone marrow aspiration, whereby we stain with Prussian blue, and and the one that has more bluish indicate iron deficiency anemia, which is on the left side. Okay, next. Okay, how can we manage patients with iron deficiency anemia? First one, we can do nutritional counseling, whereby we advise them to take higher intake of iron, and also maintain breastfeeding for infants, and also introducing solid fortified with iron during weaning. Or we can also give oral iron medication. The most common one is ferrous fumarate, and consider failure response. If we do another full blood count and it still indicate that there is low hemoglobin, we can consider it as a failure response. Either it is due to non-compliance or inadequate iron dosage, unrecognized blood loss, impaired GI absorption, or incorrect diagnosis. Next. Okay, the last resort is by giving them blood transfusion. In general, basically, we do not need any blood transfusion unless it is in severe cases and there is signs of decompensation, such as cardiac dysfunction. Okay, next. Okay, settle with the iron deficiency anemia. Next, I will explain about megaloblastic anemia, and it is one of the cause of macrocytic type of anemia, which means that the size of the red blood cell is larger compared to the normal red blood cell. And the causes of megaloblastic anemia, it can be due to folic acid deficiency and also vitamin B12 deficiency. So this I will explain about folate and vitamin B12 metabolism. Basically, both of these two, they correlate with one another, whereby vitamin B12 is involved in the process of making DNA with folate itself, whereby when we take folate in our diet, it will exist in the form of dihydrofolate, will be converted into tetrahydrofolate and also methylene tetrahydrofolate. And then this methylene tetrahydrofolate will then cause the production of thymidine, which is needed for the production of DNA. And this DNA is what causing the production of red blood cell itself. So basically, vitamin B12 and folate, they correlate with another. So if there's reduction in vitamin B12, it can also affect the production of DNA. So when there is when the DNA synthesis is basically inhibited due to lesser amount of folate and vitamin B12, it will lead to ineffective erythropoiesis, leading to premature death of cells, leading to apoptosis. Hence, low number of blood cells are released into peripheral blood. So in the blood, can see that there is presence of immature and large red blood cell due to low mitotic division. Okay, next. Okay, among the sources of vitamin B12, we have fish, crab. Basically, it's the animal base. Next. And among the sources of folate are from vegetables. Okay, next. Okay, it is more common in developing country due to malnutrition. However, it is much more common in age more than 40 years. And megaloblastic anemia is one of the causes of macrocytic type of anemia. Next. Okay, among the causes, there is folate deficiency, vitamin B12 deficiency. For folate, it is due to decrease in intake of folic acid, increased requirement, alcohol consumption, drugs, or is due to secondary to vitamin B12 deficiency. Where for vitamin B12 deficiency, it is due to fully vegan diet, especially like in Indians, where most of them are strict vegetarians. It can also be due to pernicious anemia, a condition whereby it is the absorption of vitamin B12 is impaired because of lack of intrinsic factors in gastric secretions. Okay, next. Okay, so these are among the clinical features of megaloblastic anemia. Basically, it's just the same as those with iron deficiency anemia, whereby they have malaise, breathlessness, sore mouth, and basically in patients with pernicious anemia, they can present it to us with gray hair. Okay, next. Okay, so in this table, basically the most the most important one is that patients with vitamin B12 deficiency, they have delayed developmental milestone, whereby they are unable to sit alone and unable to walk. And then because when this vitamin B12 deficiency, it will lead to ineffective hemopoiesis. So this will lead to reduction in all parameters. So it will lead to pancytopenia. So when there is reduction in platelet, it can cause prolonged bleeding. And if there is reduction in white blood cell count, then child is prone to get infection. And then can also present it to us with hypotonic and also muscular weakness. Next. Okay, the most severe form of folic acid deficiency is spina bifida. So that's why pregnant mothers, we will supplement them with folic acid because we want to prevent the occurrence of spina bifida and also anencephaly. Next. So among the investigations that we can do is by doing full blood count that will reveal low amount of hemoglobin indicating anemia. And when we look at the mean corpuscular volume, it is high. And when we look at other parameters, it will reveal pancytopenia due to ineffective hemopoiesis. And then we can also do blood film where it will reveal hypersegmented neutrophils and large red cells, H macrovalocytes due to low in mitotic division. And then we can also do serum B12 and folate that will reveal low amount due to its deficiency. And the next investigation that can be done is intrinsic factor and parietal cell antibodies if we suspect the patient having pernicious anemia leading to vitamin B12 deficiency. Next. Okay, we can also do serum LDH because like what I've mentioned, when there is ineffective erythropoiesis, these cells will basically die in the intramedullary area. So there is apoptosis over there. So the serum LDH will then increase because of this apoptosis. And then we can also do bone marrow aspiration, reveal hypercellularity, megaloblasts with immature nuclei, and enlarged abnormal megakaryocytes. Okay. Okay, so here it revealed that the size of the red blood cell is larger compared to the normal red blood cell. Next. The megakaryocyte is bigger. And then for this one, there is presence of a hypersegmented neutrophil. Okay, next. Okay, so for the management is very simple. If the patient is revealed to have vitamin B12 deficiency, then we will treat them by giving them cobalamin. Whereas those who have folate deficiency, we will give them folic acid. So that is all for my part. Is there any questions? Okay, if no, Q.
I think we need to cut it short. For the next presentation, maybe you don't have to tell like everything, just like the salient point. That's a very good presentation just now, but maybe just the salient point, because I think it's very, that's very detailed, and if you want to present like 5 in 2 hours, definitely we're not going to achieve it. So it's okay, but so we can proceed with the next one.
Okay, my name is Sharafina and I'll be presenting about aplastic anemia. So as an introduction, aplastic anemia is a non-neoplastic condition of bone marrow hypoplasia that results from defective hematopoietic stem cells, meaning that eventually aplastic anemia will result in pancytopenia, meaning that all the blood lines will be decreased. Aplastic anemia can either be inherited or acquired, and the anemia is often normocytic but can be macrocytic as well. For the epidemiology, it is higher in Asia than elsewhere, and in Malaysia particularly, it is more common in Sabah, especially in the Kadazan Dusun ethnic. And the sex ratio is the same for male and female in almost all population-based studies. So the etiologies are divided into acquired and inherited. So these are the acquired etiologies. The most common one is idiopathic. Next is infectious causes, exposure to ionizing radiations like chemotherapies, chemicals, drugs, and also autoimmune diseases. So first I'll go to the pathogenesis quickly. There will be destruction of hemopoietic stem cells. This is because all the etiologies mentioned before will cause alteration in the immunological appearance of the hemopoietic cells, in which the cell will start to express non-self antigens, as you can see in the picture shown. And then immune system will subsequently target this cell for destruction. So when this stem cell is destructed, there will be low red blood cell in which the tissue cannot properly oxygenate, and our heart has to pump harder as a compensatory mechanism. And this will give symptoms such as chest pain and also shortness of breath. Besides that, there will also be low platelet counts, and this will increase the risk of bleeding, and low white blood cell, which will cause our body to be to fight off infection less effectively. So this is a summarized pathogenesis that is more specific. You can read later. For the hereditary causes, the most common genetic disorder associated with aplastic anemia is Fanconi anemia. And Fanconi anemia is a condition characterized by pancytopenia, predisposition to malignancy, and also physical abnormalities such as short stature, microcephaly, developmental delay, Caffey-Aule lesions, and also absent or hypoplastic thumb. Next one is Swatchman-Diamond syndrome, which is a rare inherited bone marrow failure characterized by pancreatic insufficiency, bone marrow dysfunction, and skeletal abnormalities. And lastly, is dyskeratosis congenita, which is characterized by reticulated skin hyperpigmentation, nail dystrophy, and also oral leukopenia, as you can see in the picture on the right side. So as for the clinical features of aplastic anemia, it depends on the blood lines that are decreased. So when there is a low red blood cell, there will be fatigue and pallor. When there is low platelets, there will be mucosal bleeding and fatigue. Low white blood cell will cause recurrent infections that cause fever, chills, and rigor. But it is to be noted that lymphadenopathy, hepatomegaly, and splenomegaly are not features of aplastic anemia. If these features are found, other causes of pancytopenia should be investigated instead. So again, this is a more detailed summarized version of the clinical features, which you can read later. So as for the investigation, the first one is to do a routine full blood count to find evidence of pancytopenia and also low reticulocyte count. Next one is blood film, but the blood film is often described as a boring blood film, and we can find normochromic, normocytic anemia or microcytic, and also leukopenia and thrombocytopenia with normal morphology. So this is an example of the blood film. Next one is a bone marrow examination where you can do a biopsy and aspiration to access the cellularity and also the cellular detail of the bone marrow, which will show hypocellular marrow. So this is an example of a normal bone marrow, and the left one is a hypocellular bone marrow. So lastly, for the management, second last, for the management, we have to identify and eliminate the underlying cause. But the general one, we have supportive therapy and also specific treatment. For supportive therapy, we treat the anemia with red cell transfusion, thrombocytopenia with platelet, and leukopenia with prophylactic antibiotics to prevent infection. And as for the specific treatment, we do bone marrow transplant, immunosuppression, and hemopoietic growth factors. And lastly, for the prognosis, spontaneous recovery from pancytopenia rarely occurs, and if it is left untreated, severe pancytopenia has an overall mortality of almost 50% within 6 months of diagnosis. And poor prognosis is when 2 out of these 3 criteria shown here are achieved. So I think that's all for my presentation.
Okay, that's very good. Actually, I've got a few comments. Actually, plastic anemia is very interesting, and this is one of the differential diagnosis, especially the one that is congenital in origin but non-syndromic. So basically, plastic anemia you can divide into congenital or acquired, and then congenital you can divide into associated with syndrome or non-syndromic. Okay. Occasionally you will meet patient with those non-syndromic congenital acquired aplastic anemia, congenital aplastic anemia. So these children actually, they are very similar. I mean, phenotypically they are very similar to thalassemia. So you won't be able to differentiate them. So in your exams, sometimes you get patient with typical features of thalassemia. However, without investigation, you won't be able to differentiate between the two. So aplastic anemia should be in your differential diagnosis of thalassemia. Okay, that's one thing. And then acquired most of the time acquired aplastic anemia are seen in elder children rather than younger children. Younger children, most of them are actually Fanconi in origin. Most of them are Fanconi or syndromic. The acquired are seen mostly in older children, teenagers, or old people or adult. And if the causes is actually autoimmune, most of the time is secondary to infectious. So actually one of the mainstream of treatment is actually we give thymoglobulin, usually horse or rabbit if I'm not mistaken. Usually we start with horse thymoglobulin and then we give rabbit thymoglobulin. That's it I think. The rest you can read I think. Okay, thalassemia. Hey, by the way, any questions? If you got question to the, I think because we are short of time. So if you got any questions, like burning question, you can, I think you can stop the presenter in between and you can ask. Okay, so that rather than we focus on the presenter, we focus on the audience. So we can tackle the things that you want to know and the things that you think you don't know, and the thing that you think the thing that you think is more important for you rather than the thing that important for the presenter. Okay, understand kan? Okay, so boleh proceed lah dengan thalassemia.
Assalamualaikum. I'm Shapatin. I will present next hematological disorder, which is thalassemia. Next. Next.
So who's taking care of the slides?
Kejap doktor. Dia
Hina.
tersekat. Sorry, kejap.
Tak apa.
Tapi you boleh describe dulu. You just start your brief, your introduction.
So thalassemia, it is a form of hemoglobinopathy under quantitative type, which means that there is reduced or total absence of synthesis of globin chain. This one. Okay, next. So to revise, this is the hemoglobin structure consisting of 4 polypeptide chains, alpha, 2 alpha and 2 beta. Each chain is attached to a heme group composed of 4 pyrene attached to an atom. Next. So these are types of hemoglobin present in adult and also fetal. So in adult, we can see high percentage of hemoglobin A with structural formula of alpha 2 and beta 2. Fetal have a high percentage of hemoglobin F, alpha 2 and gamma 2. Next. From this figure, we can see that at the age of 6 months, postnatal age, most hemoglobin F present at birth has been replaced by hemoglobin A. So there is more beta globin chain. Therefore, the clinical manifestation of hemoglobinopathies affecting beta chain are delayed until after 6 months of age. Next. Okay, as a definition, thalassemia refers to a group of genetic disorder of globin chain production in which there is imbalance between alpha and beta globin chain production. So the basic pathology is there is reduced or total absence in synthesis of involved hemoglobin, leading to hemolytic type of anemia. This lifelong disease requiring lifelong treatment. It is an autosomal recessive disorder, therefore there is carrier state. Next. So in Asia, nearly 150 to 350 babies born with thalassemia. Most of the population are unaware about their carrier status. So in Malaysia, the most common types are beta and alpha thalassemia, mainly found among Malay and also Chinese. Sabah also has highest number of patients with high prevalence among Kadazan Dusun ethnic. So these are the carrier rates in Malaysia. You can see HBE carrier also exist. So HBE carriers are mainly in the northern peninsula state. Next. Thalassemia can be classified into minor or carrier or trait, intermediate and also major. So in minor thalassemia, usually patient is asymptomatic. hemoglobin between 9 to 11 and usually does not require any treatment. For intermediate, they have milder type of disease with later onset, usually thalassemia intermedia between 2 years old to 6 years old. And their hemoglobin is ranged between 7 to 9. They require transfusion 3 to 4 monthly or even lower than that. And then for major thalassemia, they are very symptomatic with hemoglobin lower than 5 deciliter. They are transfusion dependent almost monthly. Next. So beta thalassemia, it is a total absent or reduced amount of beta globin chain synthesis as a result of point mutation in chromosome 11. So genotype for normal person is beta. Beta thalassemia also classified according to the genotype. Next. So when there is a point mutation in chromosome 11, there will be reduced or absent beta globin chain. So there will be excess alpha chain which are unstable, forming inclusion damage red blood cell membrane. So it will cause ineffective erythropoiesis, and some red blood cells with inclusion can enter the circulation. Next. So when they enter macrocirculation, it can cause extravascular hemolysis. Both intramedullary disruption and extravascular hemolysis are responsible for hypochromic microcytic anemia. They can stimulate further increase in serum erythropoietin, causing further increase in intramedullary and extramedullary hemopoietin, resulting in marrow expansion, depicting as thalassemia phases and hepatosplenomegaly. So this is the summarized diagram. Next. So hemoglobin E, it is a beta chain variant, qualitative type. When there is mutation at position 26, where amino acid glutamine is replaced by lysine, the carrier rate is very high, including Malaysia. The person who are hemoglobin E carrier and even have this hemoglobin E disease, usually they are clinically insignificant or asymptomatic. However, if the HBE carrier or HBE disease patient marry a beta thalassemia carrier, their child can have exhibit thalassemia-like disease, which is clinically significant. Next. Alpha thalassemia, it is an absent or reduced synthesis of alpha globin chain due to deletion of alpha globin gene in chromosome 16. There are two main types of beta thalassemia, a major and also intermediate. So beta thalassemia major is the most severe form. I'm sorry, alpha. So alpha thalassemia, when only mainly the important classification is that when there are 3 deletions and also all deletions of the alpha globin. So when only 3 of alpha globin genes are deleted, this is called alpha thalassemia intermedia. So affected children can have mild to moderate anemia, but occasional patients are transfusion dependent. It is also called as hemoglobin H disease. And then the most severe alpha thalassemia or alpha thalassemia major is HB Bart disease or HB Bart hydroxyphthalate. It is caused by deletion of all 4 alpha globin chain. So no hemoglobin adult can be produced because hemoglobin adult needs 2 alpha globin. And then this alpha thalassemia major or HB Bart disease can present in mid-trimester with fetal hydrops, which is always fatal in utero or within hours of delivery. Next. So for hemoglobin hemoglobin H disease, when there is deficiency of alpha globin synthesis, will lead to increased gamma and beta globin chain production. Gamma if the patient is still a fetus, while or newborn, while beta is as we know in older children or adult. So this will cause excess beta chain that will form tetramer. It is insoluble and rarely precipitate. So the erythropoiesis is apparently effective. The anemia is mainly due to unstable nature of hemoglobin H. So hemoglobin H can precipitate in red blood cell as they age. Next. HBH H inclusions can cause membrane damage and subsequently can cause obstruction in splenic circulation, causing extravascular hemolysis. Next. So for hemoglobin Barr disease, there is total absence of alpha globin chain production. So there will be an excess gamma chains forming uh, insoluble gamma tetramers, including HB bars, 80% also HB Portland. So these are high. They have high oxygen affinity, which is not effective in carrying oxygen, causing tissue hypoxia, and usually the survival of fetus at third trimester is due to the hemoglobin Portland production. Next. So this is a picture of hydrospitalis where they have ascites and also edema. Next. For clinical feature of thalassemia, they have anemia, pallor, jaundice, splenomegaly and hepatomegaly, thalassemic phases, which are frontal bossing, maxillar hypertrophy, and depression of nasal bridge, and also features of iron overload such as retarded growth, endocrinopathies, skin color changes, become bronze or Asian gray-green, and also cardiovascular problem. Next. So for complication in thalassemia patient, they can have mainly iron overload because there is high transferrin saturation, which is due to frequent blood transfusion or ineffective erythropoiesis, leading to increase in iron absorption. So there will be subsequent formation of non-transferring binding iron or free iron in the plasma, and this free iron in the plasma can deposit into the organ. Okay, next. 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 So other than that, the complication is that they can form antibody or alloantibody formation to transfuse red cells in patient. So it will make difficult for the patient to find compatible blood. And then complications include infection. However, it is uncommon. The infection include hepatitis A, B, C, HIV, and also malaria. Next. So these are investigations that can be done in patient with thalassemia. Blood count, we can see hypochromic microcytic anemia. Peripheral blood film, we can see after this. Liver function test, we can see elevated and conjugated bilirubin. Serum ferritin is elevated. We do hemoglobin analysis, DNA analysis, and also red cell phenotyping, which is required before first transfusion. Next. Also, we can order for pre-radiograph, skull X-ray, and also chest X-ray On skull X-ray, we can see expansion of marrow. We call it as hair on end appearance. And we can also order for CT scan to confirm the extramedullary hematopoiesis and also iron deposition. Next. So from peripheral blood film, we can see anasopoikilocytosis, target cells. Next. Basophilic stippling and nucleated red blood cell. Next. So for management of thalassemia patient, the main treatment for transfusion-dependent thalassemia patient is to have regular blood transfusion, also iron chelation therapy. Next. So the aim of blood transfusion therapy is to suppress extramedullary hematopoiesis while minimizing complication of under transfusion and to maintain their well-being. So these are guide for according to patient who have thalassemia major. Next. Thalassemia intermedia and also for alpha thalassemia. Next. So for iron chelation therapy, it is to prevent iron overload in transfusion-dependent thalassemia. Currently, there is 3 approved iron chelator available. Next. One of them is dexferrioxamine. It can be started at age more than 3 years old. The aim is to maintain serum ferritin below 1000 microgram per liter. It is given together with vitamin C to augment iron excretion. And also, however, it has complications such as local skin reaction, neurasthenia infection, and also ocular and auditory toxicity. Next. So for diet and supplements, patient can take oral folate, low dose vitamin C to augment iron excretion with DESPERA. Avoid iron-rich food such as red meat, iron 45 series, and milk. And drinking tea is advised to aid in reduction of iron gastrointestinal absorption. Dairy products are also recommended because it is rich with calcium, and supplement like vitamin E, so calcium and zinc is also recommended. Next. So for splenectomy, it is indicated when there is evidence of hypersplenism, more than 2 cm. More blood consumption volume of red blood cell is more than 1.5 times normal, or annual transfusion requirement is between more than 200 to 220 milliliter per kilogram in patients more than 5 years, above 5 years of age. Also, we need to take note of below statements for prior to splenectomy. Next. So, bone marrow transplant, it is a potential curative option when there is a HLA compatible sibling marrow DNA. Patients are classified into special risk group based on these 3 risk factors: hepatomegaly more than 2 cm, irregular iron chelation, and also if there is presence of liver fibrosis. So the best result is performed at earliest age possible in class 1 patient. So next, this is the special risk group and outcome following bone marrow transplantation. They have 3 classes and also adult. That's all from me. Okay. Is there any question?
Any questions? So actually, so in general, the most important hematological problem that you have to understand and you have to grab is actually first is nutritional anemia, and then second thalassemia, and then third is the G6PD deficiency. Aplastic anemia is quite rare. And then the other one is apa tadi? Apa the other one? Apa yang I miss?
Sorry?
EP.
EP tu apa EP?
ITP.
ITP ada satu so ITP lah lagi satu. And then actually I just want to comment a bit on, you've mentioned about vitamin C kan. So vitamin C is only prescribed on patient with desferal and it has to be eaten with desferal. Faham? So you makan vitamin C and then you ambil desferal. So without desferal, because desferal you only transfuse desferal for like 5 to 8 hours per day, and only for about 5 to 6 days per week. So the day without desferal, you should not take vitamin C. And then in general, patients with thalassemia should not be given vitamin C, and they are not they are discouraged to drink vitamin C containing drinks or apa tu, oranges, papaya ke tomato. They are discouraged from this because vitamin C increase iron absorption. However, if they are on desferal only, we will give vitamin C. Okay, and then ni apa tadi? And I think you have to, basically we no longer use the minor, intermediate and major classification of thalassemia phenotypes. We are using now is transfusion dependent or non-transfusion dependence, because I think most of you will be a bit confused when you learn about thalassemia, if we keep on talking about minor, intermediate and major, because for example, in beta, you've got the minor, intermediate, and major, but in alpha, it's slightly different. Okay, you don't have major in alpha. You just got like minor, but minor is actually a carrier or a trait. But intermediate is HbH disease. So when someone said he's got alpha thalassemia, that's mean he's phenotypically he's an intermediate thalassemia. There's no major thalassemia, no major alpha thalassemia, because major alpha thalassemia, most of them died already in utero, or they born with hydrocephalus and subsequently die lah. And hydrocephalus is actually, the problem is they've got chronic anemia in utero, which leads to heart failure. So that's why they develop this edema, ascites, pleural effusion, and finally they succumb to death lah. Apa lagi? Okay.
Doctor, I have a question. Regarding thalassemia, about the hypersplenism.
Yes.
Is it occur because of frequent blood transfusion, or is it because of something else? And if the patient had to increase blood transfusion requirement, does it mean that patient has hypersplenism?
Okay, no. Actually, hypersplenism has its specific definition, and nowadays we are moving away from splenectomy because the mortality post splenectomy is much higher than mortality secondary to transfusion. So that's number one. And then second, it can be both over transfusion and under transfusion. If you over transfuse and then your spleen will have to work harder to destroy. There's more red blood cell to be destroyed. Okay, and then but if you're under transfused, then also you will have your spleen will also play a role of for blood cell production. So this will also increase the size of your spleen, and it's a vicious cycle. You know, when the spleen is bigger, so I always forgot the term. The reticular, I think you call it RAS system in the spleen is actually, the fenestration is smaller because the size is bigger. You know, the spleen got capsule now. So if the interstitial or the cell itself increase, so the smaller fenestration. So increase, there'll be increase in hemolysis, extravascular hemolysis or intramedullary hemolysis, what we call it. So this lead to further like congestion of the spleen, and spleen will become larger and larger. So spleen enlargement can be both because of high over-transfusion and also can be caused by under-transfusion. But in general, we are moving away from splenectomy. Okay. Okay, ada questions? Does that answer your questions?
Yes, okay, thank you. Sir.
Okay. Okay, nowadays, previously we said thalassemia is non-curable, but now it's actually a curable disease with transplant. Okay. I've got few patients. I think I've got 2 or 3 patients post-transplant and success. And then actually according to Majlis Fatwa, thalassemia is a reason for abortion. I mean, mother who pregnant thalassemia major babies are allowed to TOP lah. Okay, provided they did a genetic testing in utero. So if it's confirmed beta major, then they're actually allowed. I mean, Islamic jurisdiction allowed for TOP. Okay, boleh. Okay, next.
Assalamualaikum warahmatullahi wabarakatuh. We continue the presentation on G6PD deficiency and other hemolytic anemia. Next. So, hemolysis is the premature destruction of the red blood cell. The normal red blood cell survival time is about 3 months or 4 months, 120 days. And in hemolysis, the red blood cell survival is shortened, which is less than 120 days. Therefore, the red blood cell count falls. To compensate this condition, there will be increased erythropoietin. Then, next. Then there will be marrow erythropoietic increase in the marrow erythropoietic activity and leads to compensatory erythroid hyperplasia. An increase in the red blood cell production reflected by the increase in the reticulocyte count. Next. So in the hemolysis, there will be increased degradation of the hemoglobin, resulting in the indirect hyperbilirubinemia, increased biliary excretion of heme pigment derivative, and formation of bilirubinate gallstone. At the same time, during hemolysis, the hemoglobin binds to haptoglobin and increase their clearance through the kidney. And oxidized heme binds to the albumin and form metalbumin. When this capacity of the heme binding molecules is exceeded, the free hemoglobin will be appear in the plasma. So the free hemoglobin in the plasma will be dissociated into dimers and filtered out by the kidney. Then this free hemoglobin will be reabsorbed in the proximal convoluted tubule. And when it's being reabsorbed, the iron is being removed and stored as hemosiderin. Then the renal epithelial cell which contain the hemosiderin will be sloughed off and excreted into the urine, so that we can see there is urine hemosiderin appear as brownish color of urine. And then if the capacity of the kidney to reabsorb the free hemoglobin in the urine is being exceeded, the free hemoglobin will be appears in the urine. Next. Next. These are the clinical and laboratory features that suggestive of hemolytic anemia, which has been mentioned before. Next. So the hemolytic anemia can be classified. The first one is according to the site of hemolysis, whether is occur intravascularly or extravascularly. The second one is site of defect, which is intracorpuscular or extracorpuscular. Intracorpuscular meaning that there is cellular abnormality of the erythrocyte, while the extracorpuscular meaning that there is extracellular abnormality of the erythrocyte, and it can be classified also into inherited or acquired, immune mediated or non-immune mediated, and also acute or chronic hemolytic anemia. This is the example of disease, hemolytic anemia, according to the site of destruction. Next. 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 And these are the example of hemolytic anemia according to the site of abnormality. Next. Next. And these are the inherited and also acquired hemolytic anemia. You can read later. Next. So I will proceed to the G6PD deficiency. Next. As an introduction, glucose 6-phosphate dehydrogenase is the rate-limiting enzyme in the pentose phosphate pathway. The pentose phosphate pathway is the alternative pathway for generation of NADPH. So G6PD will reduce NADP, as you can see. It reduces NADP to NADPH while oxidizing the glucose 6-phosphate. So NADPH is very important for the production of reduced glutathione, which is GSH. The function of GSH is that it will prevent or protect the red blood cell from the oxidative damage. The pentose phosphate pathway is the only source of NADPH in the red blood cell. Therefore, in patients who has G6PD deficiency, they are susceptible to the oxidant-induced hemolysis, which are caused by the certain drugs, infection, or chemicals. Next. Next. So G6PD deficiency is the commonest enzymatic disorder of the red blood cell. It mainly affects the people at the West Africa, Mediterranean, Middle East, and also Southeast Asia. Is an X-linked recessive disorder, meaning that it predominantly affect the male, while the female is affected when there is a homozygous or when there is X-linked X chromosome inactivation. Next. So as for the epidemiology, it is estimated about 400 million people worldwide have G6PD deficiency. In Malaysia, the prevalence of male G6PD deficiency is highest in Chinese compared to Malay and Indians. Next. And it is significantly lower in females. In Malaysia, all newborn babies are screened for G6PD deficiency using the blood from the umbilical cord at birth. Next. As for the clinical manifestation, most of the individuals with G6PD deficiency, they are asymptomatic unless they are triggered by certain infection, drugs, or injection of chemicals, including the fava beans. The hemolysis usually occur within 24 to 48 hours of ingestion of these oxidative properties, and a patient will have the signs and symptoms of anemia such as pain, lethargy, dizziness, palpitation, difficulty in breathing, and also chest pain. And they can manifest signs and symptoms due to hemolysis such as jaundice and also dark colored urine. In G6PD deficiency, the hemolysis can be intravascular or extravascular. And according to the illustrated textbook of pediatrics, the hemolysis in G6PD is predominantly intravascular. Therefore, commonly, patients with G6PD deficiency come with dark urine. For other clinical features, they can manifest as neonatal jaundice, which the onset usually 3 days of life, and also continuous congenital hemolytic anemia, which is very rare. Next. These are the example of drugs and also chemical which can cause hemolysis in children with G6PD. Next. Okay, as for the investigation, the diagnosis of G6PD is made by measuring the G6PD activity in the blood cell. You can see the number 2. We can measure the G6PD activity by direct enzyme assay. However, during the hemolytic crisis, the G6PD level is very high due to higher enzyme concentration in the reticulocyte. Therefore, we must repeat the direct enzyme assay after the hemolytic episode has over in order to confirm the diagnosis. The second one is by fluorescence spot test. In this test, the whole blood is floated onto a filter paper, and then the dried out blood is then immersed into a solution to detect the production of NADPH. If the sample is strongly fluorescent, then meaning that the patient is normal or only has slightly depressed T6PD activity. However, when the blood spot does not fluorescence, this means that the patient has T6PD deficiency. As for the findings on the peripheral blood smear, we can see that there is microspherocytes or bite cells, and also spatial stain can document the production of His bodies. The confirmatory testing using the molecular, genetic, and also DNA methods is available but not routinely used. Next. These are the, as you can see, the bite cell and also the His bodies. Next. Next. This is the fluorescence spot test. Next. And these are the additional tests to diagnose hemolysis. I have explained before. Next. As for the management, treatment of neonatal jaundice and also chronic hemolysis is based on the severity. In mild cases, usually there is no treatment is required. In intermediate cases, patient might need phototherapy. In severe cases, the patient may require exchange transfusion. As for those with chronic hemolysis, which is very rare, the routine supplementation with folic acid may be required. For the treatment of acute hemolysis episodes, we must stop the offending drugs, treat the underlying infection if there is any, hydration and blood transfusion if necessary, and we must advise the parents on signs of acute hemolysis such as pale jaundice and also dark urine, and list of drugs, chemicals, and also food to avoid. These are the other hemolytic anemia. I will briefly explain. Next. For the hereditary spherocytosis, is the common cause of inherited hemolytic anemia and red cell membrane disorder. Is autoimmune dominant disorder in which approximately occur 1 in 2,000 to 5,000 persons. Clinically, it can be asymptomatic to regular blood transfusions, and hemolytic spherocytosis is characterized by increase in osmotic fragility and spherocytosis in the peripheral blood. And also, patient with HS will has higher risk for aplastic crisis if they are exposed to the parvovirus infection. Next. As for the diagnosis, the blood film is usually diagnostic. In the blood film, we can see there is erythrocyte, which is varies in size. The spherocytes are smaller in diameter, and there is lack of central payload due to elevated hemoglobin concentration. And the more specific tests, such as dye binding assay or osmotic fragility, is seldom required. The osmotic fragility test is not specific to HS because osmotic fragility test we positive in other disease that can cause spherocytosis. So in autoimmune hemolytic anemia, they can also have spherocytosis. Therefore, to differentiate between IHA and also HS, we must do direct COMS test. IHA with positive direct COMS test HS, negative direct Coombs test. Next. For the management, most children have mild chronic hemolytic anemia, so they only require folic acid. Okay. Splenectomy is curative, but only indicated in severe to moderate hereditary spherocytosis. A patient with HS can have aplastic crisis due to parvovirus B19 infection, and this patient usually need 1 or 2 blood transfusion over 3 to 4 weeks when there is no red cell are produced. Cholecystectomy is only indicated if the gallstone are symptomatic. Next. Next. For the Southeast Asian ovalocytosis, is common in individuals from New Guinea, Malaysia, Indonesia, and also Philippines. It caused by defect in the transmembrane protein BAN3. So, is autosomal dominant disorder where the heterozygous children will have mild to asymptomatic problem. The homozygous children, the homozygous disorder is lethal. The Southeast Asian ovalocytosis is usually associated with neonatal hyperbilirubinemia, but no hemolysis in later life. Next. So SAO is suggested. It suggested through the blood film, we can see there is ovalocytes and a bar across the central pallor. And a patient with SAO does not require any treatment beyond the newborn period. Next. The next one is the hereditary eleptocytosis. It has similar clinical and laboratory findings as HS. It has a defect in the alpha spectrum or beta spectrum. HE is autosomal dominant. Most HE patient does not have any clinical significant hemolysis. As for the blood film, as you can see, there is eleptocytosis, and the eleptocytosis is usually normochromic and normocytic with varying degree of elongation, and other abnormal red blood cell shape such as spirocytes and also folliculocytes can also present. Next. The next one is the paroxysmal nocturnal hemoglobinuria. Is very rare disorder in children. Is an acquired disorder of the cell membrane. In this patient, the pathophysiology is that the underlying somatic mutation will propagate into clonal population of the stem cells, so that all the blood cells derived from these mutation progenitors, especially the red blood cell, are susceptible to complement-mediated destruction. Next. Therefore, patient with PNH might have a serious complication, which is thrombosis and also thromboembolic phenomenon. Next. Okay, about 60% of the pediatric patients have marrow failure, and others have either intermittent or chronic anemia. The nocturnal and morning hemoglobinuria is classical finding in adult, and hemoglobinuria is very rarely seen in the children. Next. As for the investigation, flow cytometry is the diagnostic test of choice for PNH. And initially, this patient have normochromic normocytic anemia. However, if iron deficiency develop, they will have microcytic hypochromic microcytic anemia. On the blood smear, we can see there is poikilocytosis and also anisocytosis may present. As for the management, we can give eculizumab therapy This medication is a monoclonal antibody against complement component C5. So it will decrease the rate of hemolysis and reduce risk of thrombosis. The next one is the hematopoietic stem cell transplant, which is a therapeutic treatment, particularly for children, and is only indicated in patients with severe aplastic anemia. Glucocorticoids can also be given for acute hemolytic episodes. Prolonged anticoagulant therapy can be given if there is thrombosis. Iron therapy is given if there is chronic urinary loss of hemosiderin. As for the sickle cell anemia, is the most common inherited disorder in children in many European countries. So is autosomal recessive disorder. There are three main forms of sickle cell disease, which are the sickle cell anemia, HBSS, HBSC, and also sickle B thalassemia. And as for the carrier of a sickle trait, can be inherited from one parent, HBS inherited from a parent, and a normal beta globin change is inherited from other parents. So a patient with sickle trait does not have any symptom, but they can transmit the HBS to the other offspring. As for the clinical features, sickle cell anemia is vary according to the different individuals and also according to the different form of the sickle cell disease. And it can cause sickling crisis as stated up there. You can read for details later. As for the investigation, the main thing is that in sickle cell anemia, we can do sickle death test. It's very specific to identify the sickle cells. For the management, it's same like other hemolytic anemia, but in a patient with crisis, we must admit the patient, give oxygen supplement therapy, IV fluid, antibiotic, and blood transfusion if necessary. Next. The next one is the pyruvate kinase deficiency. Is an autosomal recessive disorder where the patient will have deficiency in the pyruvate kinase. You can see from the pathway there. So when there is a less amount of pyruvate kinase, there will be impaired conversion of phosphoenopyruvate to the pyruvate. Therefore, this patient has less ATP production from the pathway. And then as a consequence, from the decreased ATP, the red blood cell cannot maintain their potassium and water content. The cell become rigid and their lifespan become reduced. As for the clinical manifestation, it can vary from severe neonatal hemolytic anemia to mild, well-compensated hemolysis. For the diagnosis, in the blood film, we can see there is poikilocytosis and the PK deficiency is confirmed by direct enzyme assay. Next. And the last one is the autoimmune hemolytic anemia, IHA, is characterized by the presence of autoantibodies that bind to the patient's own erythrocyte, leading to premature red cell destruction. IHA in children is relatively rare. It only occurs about 0.8 to 1.25 cases per 100,000 children. The signs and symptoms are non-specific and similar to other hemolytic anemia. It can be categorized as warm or cool IHA. Next. As for the warm type IHA, is most common form of primary IHA in the children, accounting for 60 to 90% of the cases. While the cold IHA is relatively uncommon in children, primarily about 10% of the cases. The warm and also cool type of IHA can be further divided into primary or idiopathic and also secondary IHA. Next. These are the differences between warm IHA and also cool IHA. For the warm IHA, it involves the warm reactive autoantibodies, usually the IgG that binds to the red cells at 37 degrees Celsius. As for the cool IHA, in this disorder, the IgM autoantibody binds to the red cell at about 4 degrees Celsius. And in the blood film, for the warm IHA, we can see there is spherocytosis, but spherocytosis is less marketed in the cold IHA. Next. These are the other non-immune hemolytic anemia. You can read later. Next. These are the summary for the diagnostic clues based on the red blood cell shapes on the blood film. Okay, that's all for me. Any question?
Okay, that's very good. I just want to give one like interesting info. Actually, eculizumab is the most expensive drug in the world. Okay, the drug to treat proximal nocturnal hemoglobinuria is actually eculizumab lah. It's actually the most expensive drug in the world. Otherwise, the rest is actually you can read lah. Any questions? Hemolytic anemia is very important because it's a medical emergency in a way that it's something that is not that rare, especially this is PD deficient like in crisis. For sickle cell also is not that rare if you stay in Pahang or around UIA area is not that rare, but it's more common in KL lah because there's a lot of immigrants in UIA and also in KL lah. And the main problem with the crisis is actually the venous occlusion rather than hemolysis. In sickle cell, when they develop crisis, the hemolysis is not really the issues lah. Rarely is the main issue, but the main problem is actually unless if they've got heterozygous sickle and thalassemia, then they are prone to hemolysis. But usually the main problem is venous occlusion and also the thrombosis, and they come with severe pain. And if you got one, basically if you on call, medical on call or pediatric on call, if you got one sickle cell with venous occlusion with pain, with crisis, you will never sleep because they will shout in pain like hell and they will disturb your sleep lah. So any other question about hemolytic anemia before we go to the last one? Ada? Okay, then we can proceed with ITP.
Okay, hello, Assalamualaikum. My name is Hami. So let's proceed with the last part of the seminar, which is immune thrombocytopenic purpura. Next. So first of all, immune thrombocytopenic purpura, or previously known as idiopathic thrombocytopenic purpura, is a benign self-limiting disorder in which it can resolve by itself without any treatment, and is characterized with isolated thrombocytopenia, which means there is reduction of platelet. Meanwhile, the other parameter within the full blood count is within the normal range. Plus is in the absence of an underlying cause. Okay, next. So for the classification of ITP, it can be classified into two methods based on the etiology, whether it is primary, which means the ITP occur without any association with other disorder. Meanwhile, for the secondary ITP, there will be thrombocytopenia with other associations such as infection or lymphoproliferative disorder. Apart from etiology, the ITP can also be classified based on the phases of the disease, which include newly diagnosed ITP, persistent ITP, chronic, and also severe ITP. Okay, next. So for the distribution of the ITP, is the most common cause of thrombocytopenia in childhood. So it usually affect patient age from 2 to 10 years old, and the incidence always at the top in patient age 1 to 4 years old. And most of the case, about more than half of patient with ITP, before the presentation, there will be preceding viral infection. Therefore, in the history, we should ask patient if they had any previous fever before the complaint of increased bleeding tendency. Apart from that, both male and female patient share the same probability to get immune thrombocytopenic purpura. Next. So for the mechanism on how ITP occur, so to make things simple, so there will be autoimmune reaction towards platelet in which location? Exactly in the spleen. So there will be destruction of the platelet due to autoimmune reaction. Hence, there will be thrombocytopenia. Patient will have low platelet. Therefore, to compensate this problem, there will be increase in the production, not platelet, but the immature form of the platelet, which is megakaryocyte in the bone marrow. Okay, next. So for the clinical features, the main symptom is patient with ITP will complain of increased bleeding tendency. And for the bleeding tendency, it can be classified into based on its severity. So for the mild one, it's usually involve the cutaneous bleeding, for example, petechia or purpura. Meanwhile, for the moderate one, will involve mucosal bleeding, such as hematuria or gum bleeding. And last but not least, for the most life-threatening form, it will cause intracranial hemorrhage. So patient with underlying ITP will have symptoms of increased bleeding tendency, as you can see from the slide. And apart from that, as mentioned before, about most half of the case, patient with ITP usually preceded with viral infection. So there should be history of fever as well. And then for the sign, we are going to look, we are going to see and find any sign of increased bleeding tendency, such as petechia and purpura or bruises. Meanwhile, for in the severe form, patient might have intracranial bleeding. Therefore, patient might have loss of consciousness and reduced muscle power or paralysis. Apart from that, another important thing in ITP, there should be no hepatomegaly or splenomegaly. If there is hepatosplenomegaly, so there should not be ITP. It must be the other cause of thrombocytopenia. Okay, next. Next. So for the complication. So in general, for the complication of ITP is increased bleeding tendency, but the most fearing one is intracranial hemorrhage. So for the incident of intracranial hemorrhage in a child with ITP is less than 1%. At the same time, the risk of the patient to get intracranial hemorrhage with underlying ITP can be higher if there is previous history of head trauma, use of aspirin, which can cause antithrombotic effect that can increase bleeding tendency as well, presence of cerebral arteriovenous malformation, and also very low platelet count. For the onset of intracranial hemorrhage in patient with ITP, about 50% occur after 1 month of presentation, and about 30% the hemorrhage take place after 6 months. But apart from that, the intracranial hemorrhage can also be later than that. However, early treatment such as immunoglobulin intravenously doesn't prevent the late onset of the intracranial hemorrhage. Okay, next. So actually, for your information, ITP is a diagnosis of exclusion. Before jump into conclusion that our patient have ITP, so here are some list of differential diagnosis that must be ruled out first. Next. Okay, as mentioned before, ITP is a diagnosis of exclusion, and major part of the diagnosis for ITP is based on history and also physical examination. However, there are several tests that can be performed to assist the diagnosis of ITP, such as blood count. So in blood count, there should be isolated thrombocytopenia, while the other parameter should be within the normal range, and also PBF, peripheral blood film or peripheral blood smear. So in peripheral blood film, we can see that the size of the platelet must be normal instead of reduced or larger. As mentioned before, from the physical examination, there must be absence of hepatomegaly or splenomegaly. If there is present of hepatomegaly or splenomegaly, ITP must be less likely. Okay, next. Apart from full blood count and also peripheral blood smear or film, bone marrow biopsy is also indicated in several conditions. For example, in presence of atypical features, before starting steroid therapy, if the patient not responding to the intravascular immunoglobulin therapy, and if there is persistent thrombocytopenia which take place more than 6 months, and last but not least, the thrombocytopenia recurs after initial response to the treatment. In general, the indication for sebelum in general, indication for bone marrow biopsy is nothing but to exclude the other cause of thrombocytopenia. Okay, next. So how to manage a patient with childhood ITP? So as from the definition, is actually a self-limiting disorder which can resolve spontaneously without any specific treatment. So more than half of the patient, the platelet count turn to normal value by the end of the 3rd week without treatment. However, patient can be also hospitalized if the patient have severe life-threatening bleeding, which involve intracranial hemorrhage. If the platelet count is very low with the evidence of bleeding, if the platelet count is very low but there is no bleeding, however, the patient is inaccessible to the healthcare. For example, the patient live very far away from the clinic or hospital. And last but not least is the problem is from the parent themselves, in which they had lack of confidence to take care of their children. Okay, next. So giving advice to the patient with ITP also seem as an important approach to manage patient with ITP. So among things that we should advise patient with ITP is to advise them to take some precaution with physical activities, so they can avoid themselves to be easily bleed. Apart from that, we should advise them to avoid contact sport, for example, playing football or rugby, and then seek immediate medical attention if there is significant bleed. Plus, please avoid aspirin and NSAID consumption in patient with ITP, because NSAID, aspirin is example of NSAID, because NSAID can inhibit enzyme COX-1, which can convert arachidonic acid into prostaglandin. And further metabolism is to produce the thromboxane, and this thromboxane is actually involved in thrombotic formation. However, when there is introduction or administration of the NSAID, there will be reduction of thromboxane formation, hence it will cause anti-thrombotic effect. Apart from that, patient with ITP can be observed and monitored if they have a platelet count more than 20 times unit without bleeding, or platelet count more than 30 times 10 to the power of 9 per liter with only cutaneous purpura. Also to repeat full blood count within the first 7 to 10 days to ensure there is no evidence of involving marrow disorder. So in typical features of ITP, there should be only isolated thrombocytopenia without any interruption of other parameter within the full blood count. Okay, next. However, in certain children, some medication can be given, especially in those who have life-threatening bleeding episode, which involve intracranial hemorrhage, regardless of how low or how normal is their platelet count. If the platelet count is less than 20 time units with mucosal bleeding, or for the patient with platelet count less than 10 time units with any bleeding. So for the choice of treatment, it can be either prednisolone and also IV immunoglobulin. However, both this medication doesn't have any role in increase the value of platelet. It only prevent the destruction of the platelet. For example, prednisolone, it can suppress the inflammatory process. Meanwhile, for the intravenous immunoglobulin, it can deactivate the immunoglobulin which attack the own platelet. Okay, next. So that's all for acute ITP, but I would like to include as well for chronic ITP. So for chronic ITP is defined as persistent thrombocytopenia after 6 months of onset, and it usually involves about 1/5 of patient with ITP. So for the manifestation, it is broad-wide. It can be asymptomatic, and then it can be intermittent relapsing symptomatic thrombocytopenia, and also rare persistent symptomatic and hemorrhagic disease. Okay, next. So let's jump directly into the management for patient with chronic ITP. First, counseling and education of parent and caretaker is important for patient with chronic ITP. If patient is asymptomatic, monitoring and precaution during physical activity is very essential. In symptomatic patient with chronic ITP, there should be a short course of treatment, and among the medication can be given is second line therapies such as oral dexamethasone and also intermittent anti-rhesus D in those who have rhesus D positive, and also to revisit or to do appointment to review the full blood count to exclude other cause of thrombocytopenia. Okay, next. Then splenectomy can be also a form of management in patient with chronic ITP. However, it's rarely done because the risk of patient with ITP to die due to post-splenectomy sepsis is higher than due to the disease itself. However, it's indicated if patient have life-threatening bleeding event, which is intracranial hemorrhage, or also severe lifestyle restriction with no or transient success with medication. However, in order to perform splenectomy, there is several precautions that must be taken before and also after the splenectomy. So for the pre-splenectomy, we should immunize patient against pneumococcus, hemophilus, and meningococcus. And for post-splenectomy, we should give the patient lifelong penicillin prophylaxis. Okay, next. So here are some differences between acute ITP and chronic ITP. You can study it after this. However, I would like to highlight that for acute ITP, it commonly involve children. Meanwhile, for chronic ITP, it commonly involve adults. And for the prognosis, both ITP, acute and chronic ITP has a good prognosis. Okay, next. So as mentioned before, generally patient with ITP have good prognosis. In acute ITP, but in acute ITP, most of the patient can be, the problem will be resolved by the end of the 3 weeks. And apart from that, the value of platelet can be normalized within that duration. And then for chronic ITP, which involve adult, Mostly patients with chronic ITP can live longer without any complication, and they had normal lifespan as normal as normal people. Okay, next. Okay, I think that's all from me. Thank you. Any question?
Dia marah. Okay, good. So I think ITP, that's it actually. Yeah. Pergi sana. So basically ITP, the most important thing about ITP is it's a diagnosis of exclusion. So you have to make sure so in general you have to make sure this is an ITP lah. Make sure rule out other secondary causes. So in general in pediatric, this the most common secondary causes that you have to think of is actually things like SLE, but these are actually if elder children. So if older children came with ITP kan, children like 10, 11, then there's a chances that this is actually secondary ITP. So you have to treat the primary cause, especially SLE. But it's younger children came, most of the time this is ITP lah. In the sense that this is what we call the primary ITP or idiopathic ITP. So the treatment usually is quite straightforward. Okay. And then what else? Then to call ITP. In terms of secondary ITP in younger children, the main one is actually mycoplasma. So it's almost universal investigation. Hold on. It is actually universal to take mycoplasma investigation, serology in young children with ITP. But in older children, usually is the secondary cause are usually the autoimmune like SLE lah. Okay, any questions? Actually, I think there's one topic that is quite important. That it is rare, but not that uncommon, but it's very important, which is the hemophilia. I'm not sure why not cover the topic here in this presentation, in this seminar. Tadi first topic apa? Lupa lah.
Iron deficiency.
Nutritional anemia. Itulah. Because I think hemophilia is very important topic. It's getting rare nowadays, more rare. And in fact, actually the government is heading towards stop treating or stop subsidizing treatment for hemophilia because it's very, very expensive. And actually the Fatwa Council also already came with a verdict that actually children with confirmed hemophilia A and B is actually allowed for TOP, just like thalassemia major lah. And then tu je kot. Any questions on the topics presented? Overall, I think there's a detailed presentation. However, the thalassemia part, remember when you present about thalassemia, again, when you're talking about thalassemia, the phenotype you have to focus on the dependency of transfusion or dependency on transfusion. So basically, when you diagnose thalassemia or when you present the thalassemia cases, the main type is actually transfusion dependent or non-transfusion dependent. Try to avoid using the word like minor, major, or intermediate because it's very confusing, and it doesn't tell you anything actually by saying this is intermediate or clinically it doesn't tell you anything. Okay, unless if you talk about the genotype, then that's important. But if phenotypically thalassemia, the most important is whether is it transfusion dependent or non-transfusion dependent. And then nutritional anemia is very important. It's almost always come in exams, and in also in your clinical practice, you meet a lot of nutritional anemia. Actually, the latest study in Southeast Asia, the CNAT study in 2019, end of 2018, 2019, actually they conclude the prevalence of nutritional anemia, the iron deficiency is actually about 5%. So 5% of children, but these are mainly in urban, because the children included in the study are mainly in the urban, and we believe that is more prevalence in the rural. So the prevalence is in our population is about 5 to 10%. So definitely in every 10 children in the ward, you definitely get one with iron deficiency, and maybe another one with thalassemia, either HBE or the platelets or thalassemia carrier. Okay, good. So I think that's all. Any other questions or any opinions ke nak tambah? Hello? Dengar tak?
Dengar tak?
Dengar.
Anything else?
No.
Okay, then if there's nothing, then we can postpone the session. So kita tangguhkan speaker Farah. By the way, I think all the presenter can text me personally, then I'll give you your marks for the presentation. So kita tangguhkan speaker Farah and so terus. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Doctor.
Okay,
Thank you,
thank you.
Doctor.
Thank you, Doctor.
Thank you.